Okay, I guess we can start now. Good afternoon, everyone, and welcome to the first session on our Do Health Systems Deliver webinar series. My name is Dr. Khalid Al-Dosari, a health policy manager at the Center for Value in Health, a think tank committed to accelerate the health system towards a high-value health sector. When I first heard about Paris, of the word Paris, the first thing that came in my mind is the French capital. And I was asking myself, how is that related to health and care? It turned out to be something much bigger than a city, a multiple countries collaboration. And actually, Paris stands for Patient-Reported Indicator Survey. In this session, Paris at a glance, understanding patients, providers, and health trends, we will explore how the OECD's Patient-Reported Indicator Survey, PARIS, sheds light on the role of Paris in measuring patient-centered care, key health trends and emerging from patient-reported data in Saudi Arabia, provider characteristics and their influence on patient outcomes, indicators of Saudi Arabia's healthcare system performance. Saudi Arabia's participation in this project, despite not being an OECD member, illustrates a national commitment to benchmarking our healthcare services against global standards. We hope to gather actionable insights that can guide policy decisions and enhance the health sector performance in the kingdom. It's my pleasure to introduce Dr. Sara Al-Munif. She is the Director of Value Measurement at the Center for Value in Health and the National Project Manager for Paris in Saudi Arabia. Since 2019, she led Saudi Arabia's participation in the OECD's Patient-Reported Indicator Survey. She has also contributed to global health initiatives with the G20, World Economic Forum, and the Global Innovation Hub for Value in Health. A medical doctor by training, she holds a master's and doctorate in public health. In this session, Dr. Sara will provide an overview of Paris methodology and share observation from the provider and patient surveys. And discuss how these findings may shape future policy and practice. Meanwhile, during the presentation, I encourage you, the attendees, to submit questions in the chat. We will address as many inquiries as we can within our remaining time. Dr. Sara, thank you for joining us. The floor is yours.
Thank you very much, Dr. Khalid, and good afternoon, everyone. Ramadan Kareem, and welcome to the first episode of our new webinar series, Do Health Systems Deliver, where we will discuss the results of the OECD's Patient-Reported Indicators Survey in Saudi Arabia. Thank you to our attendees for taking the time to join us today. Your presence really reflects the growing interest in patient-centered care and the role of data in shaping the future of healthcare. I also encourage you to engage throughout the session, whether through questions, comments, or even by sharing insights into our social media LinkedIn account. My name is Sara Al-Munif. And as Dr. Khalid mentioned, I'm the National Project Manager for the OECD's Patient-Reported Indicators Survey project in Saudi Arabia, and I'm the Director of the Value Measurement in Value in Health. The release of the OECD's Paris flagship report really represents a milestone in healthcare measurement, as it brings voices of patients to the forefront, providing a look at how patient experiences and their outcomes really affect healthcare across countries. In today's session, we will introduce you to Paris, the Patient-Reported Indicators Survey, and explore what it tells us about patient demographics, chronic disease prevalence, and healthcare provider characteristics in Saudi Arabia. Throughout the sessions, we will discuss the implications of these findings for health system performance and future policy directions. Before we dive into today's discussions, let me just take a moment to introduce you to the Do Health Systems Deliver webinar series. The series is designed to explore how health systems perform through the lens of patient-reported data, focusing on the OECD PARIS. Over the next few weeks, we will examine key insights from the survey and discuss their implications for healthcare policy and practice. During webinar 1, which is today's session, PARIS at a Glance, we will introduce the PARIS initiative and share key findings from Saudi Arabia's participation. We will explore patient demographics, chronic disease prevalence, and provider characteristics, setting the stage for a deeper understanding of our health system performance. In webinar 2, right after Eid, we will discuss the importance of PROMs and PREMs and how these tools help assess healthcare quality and drive value-based care. In the third webinar, we will take a deeper dive into how some metrics link to healthcare delivery capabilities to better support patients, especially those with chronic conditions attending primary care facilities. And in our final episode, webinar 4, we will compare Saudi Arabia's results with other OECD countries, learning from international best practices and discussing potential improvements for our own health system. Each of these webinars is an opportunity to gain data-driven insights, engage in meaningful discussions, and explore ways to enhance healthcare quality and equity. We encourage you to participate in the full series and be part of this important conversation. So let's get started with our first topic, understanding the PARIS project and why it matters. So first, I'll give you a brief overview of the project, where we will explore the OECD PARIS project, its objectives, why it's a game changer in measuring patient-centered care. Then we'll discuss how healthcare value is measured and the relevance of PROMs and PREMs to value. Then I'll examine the characteristics of healthcare providers working in Saudi Arabia, looking into factors that influence patient outcomes, and then also analyze patient demographics, health trends, and focusing on chronic disease prevalence and healthcare access. And finally, we will connect the insights from PARIS to policy and practice, discussing the broader implications for healthcare improvement, system performance, and decision-making. So I just wanted to start by giving you a brief introduction to Value in Health. So as you may know, the center is a body that enables continuous improvement of value in health by sharing knowledge, influencing policy, building capacity, and providing evidence-based advice on value-based care, and connecting all elements in the system towards achieving this goal. A publication of the center was the definition of value in Saudi Arabia, which we composed with the help of experts in the field of healthcare. And outcomes were displayed as a huge element of value-based healthcare in the kingdom, which is an objective of the project. The main goal of the survey is to promote person-centric care, which is a core element of value-based healthcare. It's an international survey with the participation of 20 OECD countries. So that's going to help us in assessing how Saudi Arabia is doing among these countries. And the PARIS project will help us achieve the goal of providing person-centric care by, number one, international benchmarking, which will help policymakers understand how their health systems are performing, where improvements and efficiencies can be made, and collecting comparable data from different health systems on outcome measurement, which is a topic that's never been studied. And Value in Health has been playing a national role in coordinating successful delivery of the project since 2019. So now just going back to one of the core elements of patient-centric healthcare, outcomes that matter most. Traditionally, health systems have really relied on clinical measures such as lab results, imaging, physician assessments to determine the effectiveness of care. However, these metrics alone really don't capture what truly matters to patients and their own perceptions of their health, their well-being, their quality of life. This is where patient-reported outcomes, or PROs, come into play. PROs provide direct insights into how patients feel about their condition, treatment, or daily functioning. And unlike traditional clinical evaluations, PROs come directly from the patient without interpretation from the healthcare professionals. These reports can include pain levels, mobility, fatigue, mental health, and overall well-being. To standardize this approach, we use patient-reported outcome measures, or PROMs, which turn qualitative health outcomes into quantitative data using structured questionnaires that assess patients' health status in a quantifiable way. PROMs allow us to compare outcomes across different patient groups, healthcare providers, and even across countries, similar to what we're doing in the Paris Initiative. So now let's just take a closer look on how Paris connects PROMs and PREMs to different levels of the healthcare system and why it matters for healthcare improvement. Paris is designed to capture patient-reported outcomes and experience across the three key levels of the healthcare system. On the macro level or health system, Paris data informs policy development and supports the adoption of standardized PROMs and PREMs tools at the national level or international level. By integrating patient-reported data, policymakers can really ensure that health systems evolve to meet the actual needs of the population. On the meso level, or the organizational and provider level, Paris contributes to quality improvement and capacity building within the healthcare organizations. It helps providers understand how their patients experience care, guiding improvements in service delivery, coordination, and accessibility. At the micro level, or the individual patient level, Paris data enables personalized care, allowing providers to tailor treatment plans based on patient-reported needs and experiences. It also empowers patients to actively manage their own health, reinforcing a partnership between patients and providers. By integrating Paris on these three levels, we move towards a healthcare system that doesn't just deliver services, but also prioritizes what matters to patients. So just a brief timeline of the project we've been part of since 2019. Phase 1 was planning and preparing for the project, including engaging stakeholders, translating and validating the tool, gaining access to the data, and learning from our international partners on the standardized way to conduct the survey. We also completed a phase 2, or the field trial, which was a pilot phase of the project in 2022, where we conducted the survey on a smaller group to examine the survey operations. Phase 3, or the main survey, was conducted in 2 parts. One was for patients aged 45 and older, and that data was shared with the OECD for international comparison. But nationally, we had a challenge. There was a very high burden of chronic diseases in the younger age group, which is a larger % of the population. So we decided to add a second stage and sample patients aged 18 to 44. So a bit about the questionnaire. The survey consists of 2 questionnaires. One is for patients and the other is for providers. Providers surveyed include practitioners or physicians working in a primary healthcare center that provide general care to the population. The provider questionnaire contains information about the structural characteristics of the clinic and how they provide care. We completed data collection from 100 providers from primary care clinics from the Ministry of Health, other governmental sector hospitals represented by the Ministry of Defense, and private sector hospitals across the kingdom. For patients surveyed, it includes people aged 18 and older who visited a primary healthcare center at least once in the past 6 months preceding the survey. The patient questionnaire contains information about the patient's social demographic characteristics such as age, gender, and their healthcare experiences and outcomes. And patients are linked to the provider through a nested design, which I will be showing in the next slide. But the direction was to sample 150 patients per provider, so 75 patients per age group, giving us a sample of 15,000 patients. So again, the survey employs a nested design where primary care service users or patients are nested within the primary care practitioners or providers, which are physicians in this case, which are in turn nested within primary care practices or clinics within the national or regional health system across Saudi Arabia. The design enables analysis of variations in patient-reported data in relation to characteristics of care. So I'll move on to the next section where we dive into the survey operations, focusing on how the data was collected and processed to ensure accurate and reliable results. The survey is designed to capture meaningful insights from both patients and healthcare providers, really shedding light on the quality of care and patient experiences across different health systems. So the response rates were calculated at two levels, national and sector level, to evaluate participation and data completeness. Out of 135 providers that were invited to participate in the online survey, 101 completed it, resulting in a 75% response rate. For patients, it was a bit more challenging because it was a telephone survey that took an average of 40 minutes to complete. However, it did result in a 9% response rate, which was acceptable and expected for a lengthy survey about patient experiences and outcomes. Our sampling approach ensured equal representation across all regions of the kingdom. We sampled providers and patients based on the population density for that region, and we came up with a very robust sampling technique. So during the first phase of the project, again, 100 primary care providers from various primary care practices across Saudi Arabia completed the provider survey. Organizational and provider characteristics were examined and what impact they had on patient outcomes and experiences. So of the key survey themes that were measured was practice type and location, access to care, the skill mix of providers in the clinic, the payment or reimbursement mechanism to providers working in the clinic, the digital information system implemented within the clinic, how care is coordinated in the practice, use of care plans, and provision of self-management support. So I'll start with the first theme and the result from that theme. So consistent with the demographic distribution of the country, 90% of the clinics were sampled from urban areas or cities, leaving the remaining 10% from towns or suburbs. Most providers worked in a group practice with shared patients, and although solo practices were reported, we know that they rarely operate in Saudi Arabia. This is possibly because respondents misunderstood the option when answering the questions, or respondents could have answered this question based on their specific clinics they operate in. However, we would consider that group practices with shared patients is the majority. The provider survey also included questions to assess the scope and distribution of chronic condition care across participating providers. A significant proportion of providers reported managing care for most chronic conditions. And you'll see later that arthritis or musculoskeletal pain was the most prevalent in patients, but only 38% of MOH and 60% of OGS providers provided arthritis-related care. The provision of diabetes-related care, the second most prevalent disease, was pretty high across all sectors. And overall, data suggests that private sector providers have a better coverage of care for chronic conditions compared to the Ministry of Health or OGS. Access to timely, appropriate, and affordable healthcare services is really essential for improving health outcomes. And survey findings revealed that most clinics provide walk-in appointments. However, only 25% of clinics offered services outside working hours. They also, including weekends, they also rarely provided home services. And this is an indication that although appointments are widely available, they may not be accessible or convenient for certain populations. 2/3 of the clinic utilized online consultation methods, including phone consultations, video consultations, messaging, displaying a pretty high rate of digital integration within our system. Moving on to the skill mix of providers within the clinic, the skill mix in primary care practices was pretty limited. Most physicians working in the clinics were family physicians, with a smaller number of internal medicine physicians. And beyond physicians, staff only included patient educators and nurses. There was a really noticeable absence of multidisciplinary teams such as dietitians, mental health specialists, physical therapists, and this limited and constrained skill mix constrained comprehensive and chronic disease management. So moving on to the payment structure, the vast majority of physicians operate on a fixed salary payment model. Only a few physicians working in the private sector were compensated using a fee-for-service model. 25% of practices receive additional payments dedicated towards specific goals, such as achievement of targets for screening, prevention, or referrals, and having socially or financially disadvantaged patients and working in rural or disadvantaged areas. And these payments were more common in the private sector. So nearly all clinics used electronic medical recording system, which include essential patient information such as reason for consultation, diagnosis, medical history, behavioral habits, clinical parameters and measurement, test results, and medications. However, some clinics captured additional details such as living situation, employment status, and ethnicity. Some clinics provide distinct computerized services, such as sending reminders when it's time for regular preventative or follow-up care, alerts or prompts to provide patients with the test results when they reach the practice, and guideline-based interventions and screening tests. So moving on to care coordination, most of the facilities surveyed stated that a healthcare professional in the practice team provided care coordination for patients with chronic conditions. 75% of clinics reported being well prepared to coordinate care for patients with multiple chronic conditions. However, only 40% were prepared to coordinate care for patients with severe mental disorders. And only 18% were prepared to coordinate care for patients with substance abuse. And significant gaps were really noticed for care coordination for patients with need for palliative care, long-term care, and social services. Sector-based trends were observed in provision of care for patients with chronic conditions. And the preparedness to coordinate care for the same patients groups are also reflected in the ratings for the overall quality of medical care. So in terms of care plan development, most providers stated that they do develop care plans for patients with any chronic condition. And among facilities that develop care plan for patients, it's encouraging to note that the majority of these facilities use care plans for all patients at least once a year. And finally, self-management support. Providers were asked about a variety of ways where they provide self-management support to their patients. Over 70% of patients provided verbal guidance during or after consultations. About 50% distributed pamphlets, booklets, and internet-based information. Goal setting and action planning were with members of the team practice were provided by 27% of the providers, and only 14% referred patients to self-management classes or educators. So moving on to the next section, where it provides analysis of key survey metrics for patients aged 18 and older. So there was no restriction on gender, nationality, education level, or employment status. The survey design ensured equal representation across these socio-demographic characteristics. However, there was minimal representation from non-Saudis or foreigners. And again, similar to the demographic distribution, 82% of patients lived in cities. The age distribution is sort of a bell-shaped, with the majority of respondents in the middle age group, and older age participants were minimal. The income distribution was fairly balanced across low, middle, and high income groups. A notable percentage, 32%, either don't know or prefer not to say, which could impact the interpretation of financial access to healthcare. Only a minimal amount of respondents had no to minimal education. Majority of respondents were in paid employment, making it the dominant employment category. 13% were actively looking for work, but the workforce was predominantly employed, indicating varying labor market participation. So moving on to lifestyle characteristics. Alarmingly, there was very minimal awareness about healthy eating habits and healthy lifestyles. Only 35% of respondents eat the recommended daily serving of fruits and vegetables a day. A significant proportion eats fruits and vegetables only 1 to 3 times per week, suggesting really a poor dietary lifestyle and great room for dietary improvement. The findings also highlight a sedentary lifestyle. Only 16% of respondents do strenuous activity once a day. 35% do no physical activity. However, on a positive note, there's a lower percentage of smokers, but there could be area of improvement. So moving on to the main study area, chronic conditions. While the study really broadly examines chronic care, participation was not limited to patients with chronic conditions, ensuring a diverse representation of healthcare experiences and outcomes. However, the study did reveal a very high percentage or prevalence of chronic conditions. 70% of respondents overall had a chronic disease, 82% of patients aged 45 and older, and 56% of patients aged 18 to 45. The most common chronic conditions reported were arthritis or chronic problems with back and joints in 30% of patients, followed by diabetes in 25%, breathing and hypertension, breathing conditions such as asthma and COPD in 11% of patients, followed by mental health conditions including depression, anxiety in 8% of respondents. Alarmingly, 20% of respondents reported having multiple chronic conditions, which is really a focus area for us. So the last slide I wanted to talk to was why this matters. Why are we measuring this? What are we going to do with this data? And successfully delivering the PARIS project in Saudi Arabia is a significant milestone in our journey towards more patient-centered care and more patient-centric healthcare systems. As the healthcare landscape continues to transform, PARIS provides valuable insights that will benefit key stakeholders, policymakers, providers, and patients. For policymakers, PARIS provides a systematic approach to understanding how well health systems are performing. The data will allow policymakers to help them understand how their health systems are performing, give systematic insights on outcomes and experiences, compare different care models, and identify urgent topics that need to be addressed on a national level so we can align with the reform activities. For healthcare providers, PARIS data serves as a powerful tool for continuous improvement. Through this project, providers will be able to see aggregated data and compare the results of their organization with peers and identify quality gaps to enhance clinical practice. And ultimately, the biggest impact of PARIS is on patients, ensuring that their voices drive healthcare improvements for For them, this means enhancing provider-patient communication. It will ultimately help health systems to be more centered around their needs and will enable their healthcare providers to improve quality, and provides assurance that their experiences are shaped by policy and system improvement. Finally, PAIRS is more than just a survey or a standalone project. It's a strategic initiative that will help us build a more transparent, data-driven, and patient-centered healthcare system. By using these insights effectively, we can ensure that healthcare in Saudi Arabia is not just delivering services, but also delivering better experiences and outcomes for all. Thank you for attending, and back to you, Khalid.
Thank you, Dr. Sarah, for that comprehensive overview. And surely these findings underline the importance of patient-centered data in guiding informed policy decisions. Just before we head into the Q&A, reflecting on this presentation, if I may, I have a couple of questions. So looking at this project and survey, if you can just explain briefly, why did the OECD launch this project in the first place?
Thank you, Khalid. So the OECD launched the PAIRS project following the 2017 OECD Health Ministerial Meeting, where health ministers emphasized the need to better measurement tools to assess value-based healthcare. There was a growing recognition that these traditional health metrics alone were not sufficient for healthcare effectiveness, and that patient-reported outcomes and experiences were essential for understanding healthcare from a patient's perspective. In response, the PAIRS initiative was introduced as a global effort to standardize and implement these measures. 20 countries initially committed to the project, agreeing to collaborate on the development, implementation, and integration of PROMs and PREMs into their healthcare systems. The goal is to ensure that health system performance is not just evaluated by clinical outcomes, but also by what matters most to patients, their experiences, their quality of life, their overall well-being.
Thank you very much. And what's the current situation in the kingdom in terms of the topics addressed by PAIRS?
Thanks for that question. So the PAIRS project addresses several critical areas that are central to healthcare transformation in Saudi Arabia, including number one, NCDs and chronic care. The second is the role of primary healthcare. And the third was the importance of outcome measurements. The burden of diseases in Saudi Arabia is primarily driven by chronic diseases and non-communicable diseases. We're witnessing a significant prevalence of chronic conditions, particularly among young adults, as well as you saw, an increasing trend in multiple chronic diseases per patient. And cardiovascular diseases remain the leading cause of mortality, making them NCDs a central focus in ongoing healthcare reforms. For primary care, despite wide geographic distribution and accessibility of primary healthcare services, healthcare delivery systems in the kingdom really remain heavily reliant on secondary and tertiary care, leading to fragmentation in care coordination. Strengthening primary healthcare is really essential for enhancing preventative care, early disease management, and integrated care pathways. These are all really critical for improving patient outcomes. And finally, when it comes to outcome measurements, several pilot programs have introduced various tools for assessing patient-reported outcomes, but implementation really remains inconsistent across healthcare sectors. To fully integrate PROMs and PREMs into the healthcare system, these tools need to be validated, translated, and standardized across the healthcare sectors to ensure data comparability and meaningful impact on policy and clinical practice.
Yeah, I know I said a couple of questions, but if you allow me, just one last more, and we have a few questions in the comments as well. Just looking back and reflecting on those results, since it's began back in 2019, what actions and measures have been taken within your role in the Paris project? If you can just briefly explain to it.
Sure. So as I've mentioned previously, we've been engaged in the project since 2019. So it's been 6 years now. And our role at Value in Health and working as the national project manager for the Paris Initiative in Saudi Arabia, the role is to lead implementation of the OECD project within the kingdom, ensuring alignment with both national and international stakeholders. This involved coordinating efforts across multiple entities, including governmental bodies, providers, research institutions, to really facilitate effective data collection and analysis and reporting. At the beginning, we actively engaged with the OECD and the International Consortium of Research and Academic Entities to ensure that our country's participation is fully integrated into the global initiative. We're the only non-OECD member country that participated in Paris and the only representation from the Middle East and Asia. So we really wanted to make sure that the data is representative. This included regular communications on progress, addressing challenges, sharing insights that really contributed to the overall development of PROMS and PREMS. We also engaged with multiple national stakeholders to ensure easy and smooth implementation of the survey in the country. Our key partners that are actively part of our project steering committee and are really our success factors for the project were the Ministry of Health Directorate of Primary Care, the Ministry of Health Patient Experience Center, Beneficiary Affairs from CNHI. We had engagement from the Council of Health Insurance, the Health Sector Transformation Program, and of course, Press Ganey were our partners in this. And along with other national stakeholders that gave input into the design and implementation of the survey. Additionally, we did oversee key operational aspects from survey implementation, data management, and most importantly, to ensure that the findings translate into meaningful policy and healthcare improvements.
Okay, thank you very much. And looking at the questions in the chat, we have plenty of questions. Well, the first one is, are these findings publicly available?
Yes, so the findings, the national findings are available in the OECD's flagship report that was published a few weeks ago. They published the report that internationally compares Saudi Arabia's findings with other countries. And you can see some key differences that are going on or that are specific for Saudi Arabia. Just to note, this data is for patients aged 45 and older, because there is a high prevalence of chronic diseases within that age group in the OECD and European countries. So that was their focus. So if you take a look at the report, the results only show patients aged 45 and older. However, we nationally took it a step further and measured outcomes and experiences for patients aged 18 to 45. And you can see that combined with the data I just displayed, we're again working on national publications to show our results and our for both phases, age 18 to 44 and 45 beyond, to display all our efforts. And we're really working on multiple publications to highlight our pain points, I guess, or what we would like policy change to focus on in the next few years.
Thank you very much. And the next question, in your experience post-OECD Paris Initiative, although it's fairly new, is there any automated tool recommended for measuring PROMS and PREMS?
So that's also something we've been working on and discussing with our partners. There is no standardized way to collect PROMS and PREMS within the system. There are multiple tools that are available, and we're working on collating these tools. But it's up to the provider and up to the system to look at these tools and select the tools that's most appropriate for their context. PARIS focuses on chronic diseases, and that's the PARIS's focus area. The PROMs and PREMs within PARIS are extracted from PROMIS, EQ5D, WHO Wellbeing Index, and other tools. So I can't say that there's one size fits all PROMs. We are working on collation collating tools that are available and maybe recommending what's best for each context. But at the moment, there's no standardized tool that can be implemented for the whole system in any countries that we've benchmarked or looked at.
Okay, thank you. And the next question actually talks about the next steps. And for the data itself, will the data be collected again? And is it possible to use this survey for clinical research? So what do you think about taking this a step forward?
Yeah, so that's a great question. So the OECD plans on repeating this survey every 4 years. We just completed the last round in 2024, so that's going to require a further round of stakeholder management, again, looking at the survey tool, seeing if it's appropriate and so on, and then implementing it again. But we're not just interested in international benchmarking or international comparison. We're also interested in taking the survey tool and implementing it across providers or healthcare systems within the countries. So we're urging providers to take a look at the questionnaire and extract what you think is appropriate for your context and applying it to your context. It can definitely be applied or used for research purposes to what you see appropriate. Again, it's a very lengthy tool, about 140 questions for the patient survey. So take a look at the survey. See what you would like to implement within your clinic or service, and that can be used as a great tool for quality improvement, shedding light to problems that are happening within your clinic, and so on.
Okay, and we will link also the flagship report, and you can visit also our website. We will link it also here in the chat as well. So I think this will answer the next question where he asks, where are we standing in comparison to other countries who have participated? So if you can just briefly talk about it, Sarah.
Of course. So the flagship report, or the survey itself, or the project itself, compared 20 different countries. Each country has a different healthcare system. Has also the OECD tried to ensure very similar survey methodology as much as possible. But some of the key differences from Saudi Arabia between other countries. They measured PROMs and PREMs across 10 variables. So the 10 variables were physical health, and this is what we're going to talk in the next webinar, but I'll touch on it briefly right now. Physical health, mental health, social functioning, well-being, and general health. These were the 5 PROMs measured, and 5 PREMs were measured: quality of care, experienced quality of care, self-management, support, trust in the healthcare system, confidence in self-management, and experienced care coordination. So these were the 5 PREMs measured. What we could see within Saudi Arabia's performance across the countries, it was pretty comparable. However, Saudi Arabia was lower in mental health outcomes, higher in mental health outcomes, and higher in physical health outcomes. However, they were lower in well-being outcomes. So that's very alarming. We were extremely lower than other countries in care coordination, which is, I think most of the efforts within the healthcare transformation are trying to target care coordination through the unified medical record, through referrals, through enforcing primary care, and so on. Another really special or what we perform differently in trust. So our population has very high trust in the healthcare system. People with and without chronic disease really trust the healthcare system, other than and other countries that really had a lower confidence in healthcare systems. So this can be utilized in health systems advantage, and we can really look into how these factors really affect policy. Other differences, healthcare systems, or what we found that were really different between Saudi Arabia and other countries, or that were very special for Saudi Arabia, although we had a very high digital integration within the system, the digital health literacy was low, and people really don't use these tools as required or as appropriate. That was a very alarming, I would say. The clinics that use EMR, they didn't have better outcomes and experiences than other patients. So these are things that we're really looking into, and maybe in next session we'll delve. Next webinar we'll delve deeper into PROMs and PREMs and what were the things we need to focus on and look into.
Yeah, surely. We don't want to spoil much of what's coming in the next webinar. So the next question talks generally about the alignment, how Paris is aligned with the national initiatives such as Nafis and Wasfati. How does it align with them? If you can explain briefly.
So this Paris is a cross-sectional study. It's being done once. I mean, yes, the OECD does want to do it every 4 years. However, we have not committed to doing it yet. So we're just taking a snapshot of how healthcare systems are performing from a patient's point of view. The data from Paris is all patient reported, so it does not access any patient files. Even the chronic condition status was also patient reported. So it does not integrated. It's not integrated with Nafis or any patient files. Just to ensure patient confidentiality and access to data at the higher was really confidential. Even the reporting of how healthcare systems perform and act was patient reported. So it's not integrated with Nafis or with any other electronic medical records. However, we do think that the results of Paris, we would like to take them forward and help integrate them or the results with what's happening on the national level. So yes, we saw some deficiency with electronic medical records. We're having discussions with stakeholders that are really working on EMRs and other initiatives to fix that, to incorporate patient-reported outcomes into their work on Nafis or with other. This project really focuses on value-based healthcare by looking at their patient outcomes and patient experiences and putting patients in the center. So it really drives the movement towards patient-centric care and more value-based care, which is a core element of the transformation.
Thank you very much. We still have a few more. There's one interesting one that talks about the survey itself and the challenges being the survey that extensive. The person asks, don't you find out filling surveys can be a tedious process for patients, especially when the questions are detailed? To what extent do patients cooperate in responding to these surveys, considering that low response rates and engagement are among key challenges we face in this area?
Yeah, that's a really important aspect of the project. So we did face a pretty low response rate, 10%, but it was expected due to the lengthy survey design, the lengthy survey itself. To note again, it's the first time the survey has been implemented in Saudi Arabia. or internationally. So the survey is brand new. We're making comments and adjustment as we're going. So we just reported to the OECD, as did other countries, report that it's a really lengthy survey. It's 140 questions. We completed it all over the phone with patients, just to eliminate any biases. So it was completely over the phone. We didn't introduce any other administration ways. It was only on the phone, no online administration or paper administration or so on. But through this first process, we consider this as a benchmarking. So through this process, we're really looking at the questions in the survey and deciding what's really important to us. Do we really need to ask these 140 questions? Or can we ask 10 or 20 questions that really display the importance of PROMs and PREMs and really show important data? And we can eliminate the rest. So yes, it's a very lengthy process, lengthy questionnaire. It's a tedious questionnaire. We nationally have a 9% response rate. Other countries had a 4% response rate. So we performed even better than other countries in the response rate. However, we consider that as a challenge. We're trying to adjust the questionnaire to have a final survey that's more standardized and more sustainable moving forward.
Thank you, Dr. Sarah. The next question talks about the in terms of research support in academia that support Paris project. Are you aware of any Saudi universities or entities doing research to support Paris related factors? And also talks about the role of the center. Is the role of the center to gather insights of the research agenda across Saudi in areas like this to help understand and make sense of all the different research projects?
So we've been, since we completed the data collection, we've been engaging with multiple research entities across Saudi Arabia and internationally to highlight the findings of the survey and look into how we can publish this and how others can really learn from what we did. We are a think tank, and we publish research. However, we're collaborating with mainly the University of Exeter that are helping us publish these findings and highlight the areas that we want to focus on. We've also had discussions with local universities, King Saud University, Al-Qura University, and other universities to that they can help us publish and analyze the findings and publish them. We're really welcome to collaborating with other entities, doctoral students, research fellows, and so on. This is a huge amount of data we have, and we would like it to be highlighted elsewhere. On the second part of the question, where you asked about if there's any way you can highlight these projects that are happening. So yes, there are a lot of pilot projects that are happening across Saudi Arabia that really display value-based care, not just outcome measurements, but all value-based care implementation tools. We're working on a case study library where you can access and see some of the case studies of providers or entities or patients that have applied value-based care. There are some pilot projects we've looked at that use PROMs, but there's no repository of these tools. And we urge people to publish their work, share their work, let us know what's happening and going on.
Thank you very much. Just being aware of time, if you can, I will add one more last question. If you can just briefly answer it in a minute, we try to accommodate as many as possible. So one of the questions says that the report showed one of the interesting findings was the high percentage of people with arthritis. And if you are aware, or what are the approaches used by other countries on dealing with such findings that you are aware of, especially modifying and creating policies that intervene and ensure that these data to improve the healthcare system?
Yeah, so arthritis was displayed as the most prevalent chronic disease across countries. But the question itself, or the identification of the chronic disease, was arthritis or chronic back or joint pain. So we're not sure if it's really arthritis or if it's a musculoskeletal problem. Most probably it's musculoskeletal. But we are looking into, and internationally, we are looking into policies that target musculoskeletal joint pain. They are mainly due to they're mainly focusing on the lifestyle interventions, walking, exercise, and so on. But yes, that is something we're looking into, and we would really like to focus our policy development efforts on.
Okay, I think this concludes the Q&A session. We're just about ending on time. I would like to thank you for your engagement and thoughtful questions. This discussion underscores the value of patient-reported data in identifying priorities for healthcare improvement and shaping a robust evidence-based policies. As we conclude today's session, please remember that there's just the first event session in our Do Health Systems Deliver series. The next session of the series will be on measuring what matters, the power of PROMs and PREMs, where we will explore into the outcomes and experiences that were reported by our population in the second week of April. We will have two guest speakers who will talk about their experiences with PROMs and PREMs implementation. On behalf of the Center for Value in Health, I extend my sincere thanks to Dr. Sara Al-Munif for her presentation and to all of you for your active participation. We look forward to welcome you at our next session of the webinar series, Do Health Systems Deliver. Thank you, and see you in the next session, inshallah.